we have been using proton therapy within the National Health Service for probably 10 years via an overseas program, but we've actually had high energy proton beam therapy available within the UK for NHS patients for just over the last 3 years, based at the Christie Hospital in Manchester, which is where I work. And more recently, the second NHS centre has opened at University College London, although they're not quite in a position to start taking on some of the complex sarcoma patients at the moment. I think we have learnt a lot in the last 3 years because we've been treating the majority of UK patients that have been eligible for proton beam therapy, and that's principally been two groups. So it has been the pediatric type sarcomas that occur in adults, so Ewing sarcoma and rhabdomyosarcomas, for which we really followed standard international best practice. They're treated usually in the context of a clinical trial with a combination of chemotherapy and then local therapy, which is sometimes surgery, sometimes radiotherapy, sometimes both. And then the radiotherapy is sometimes given preoperatively, sometimes postoperatively, and that depends on where the tumour is and other situations that might be relevant. So it requires an awful lot of discussion and liaison between oncology in terms of systemic therapy, surgery, and radiotherapy, as in proton beam therapy. I think the key learning is probably mainly getting the coordination right between those different groups, because certainly for rhabdomyosarcoma and Ewing sarcoma, timing and maintaining treatment intensity is really important. So having those open communication channels between the centres, because they're not exclusively treated in Manchester, they just come to Manchester for their proton therapy. So coordinating that with wherever's giving their chemotherapy and wherever's doing their surgery, because they might be in different centres, has been really important to us. And I think the most important piece of learning and for improvement is probably the talk to us early so that we know about the patient and so that we can get ourselves ready for them. Also, let us know about any particular social concerns that might need support whilst they're up here, because they may be away from home for 6 to 8 weeks, for example. And then in terms of the spinal tumours, again, it's coordination, particularly we're talking about chordomas and chondrosarcomas of the spine, between the operating surgeons, of which there's only 5 bone sarcoma surgical centres in the UK. And the radiotherapy is really important, understanding what could be achieved surgically, what the toxicity might be, the advantages of radiotherapy or surgery or a combination of both, are all things that we thought we knew about before we started treating patients in the UK. But until you actually have to see these patients and look at the complexity of the tumours and some of the really quite dramatic surgery that is done, I don't think you have a really good understanding of what's possible. And because we've been going for 3 years now, we've treated virtually all of those patients. We do have quite a strong experience base now that gives us confidence going forwards. And I think the thing that will make the biggest difference for particularly the spinal chordomas would be the ability to give some of their radiotherapy preoperatively, which is what is done at Massachusetts General Hospital in Boston with really good results, because it potentially makes the radiotherapy volume tighter and reduces some of the potential long-term toxicities, but it does require support and buy-in from surgical colleagues. So again, that relationship with our surgical colleagues and referring colleagues is really important.